Okay, we're starting on Unit 2, so this is going to be our exam 2. So this is kind of like more the labor process. This is Chapter 8. So we're going to kind of talk about how labor works, and what is the natural process of what should be occurring. So, 4 essential things that are going to need to be available for labor to be successful. We talk about them being the 4 P's. So we got to pass, and they all start with P's. Passageway, passenger, powers, and psyche. Any one of these that is not correct, or any one of these that does not work like they need to, sometimes that can be have a poor outcome for labor. So those are things that the doctor's always going to be checking, we're going to be looking for. So thinking about the very first one, let's talk about the passageway. The passageway is basically the bony pelvis. So the bony pelvis has what we call a true pelvis and a false pelvis. The true pelvis is let's talk about the false one first. The false pelvis is up here. So most all babies' heads are going to fit into there. However, the true pelvis is when it's the outlet of the pelvis. So this picture right here is more depicted on if you're looking from the bottom going up. That's where the baby's head has to come through. So the baby's head easily can get into here, but it doesn't easily come through here. It's going to have to turn and adjust and mold and change to get through there. So that's part of your passageway. So again, talking about those, when we talked about those kinds of things, we already talked about your true and your false pelvis. Then you have all these soft tissues. So soft tissues is going to be like the vaginal canal, the cervix, how everything is going to have to change to meet the needs of that baby coming through. If a mom has had a baby before, a lot of times that tissue in there is a little bit more accepting of changing or moving and all of that stuff. If it's a primip or a premapare, somebody who has never had a baby, or it's an older woman and their pelvis is more set, sometimes those soft tissues don't always change like they need to, and it's a little bit more difficult for that baby to come through. There are 4 different types of pelvises: gynecoid, platypoid, android, and anthropoid. These are all the different types of pelvises that can happen, but the most common one, and the one that is probably going to be the best for and conducive for a baby to be delivered, is your gynecoid pelvis. So the gynecoid is going to be more accepting of the fetal head and everything coming through. So a lot of times your doctor will kind of look at pelvic dimensions. Your obstetrician will do that, and they will kind of look and see what kind of pelvis that you have, and is it going to be something that the baby's going to be able to come through. Now, as far as those soft tissues, like we talked about earlier, that cervix must be completely effaced and must be completely dilated before that baby is going to be able to come through. So that cervix has to be at a 10 centimeters in order for that head to really be able to mold enough to get through. Now, obviously, when we talk about the passenger, we'll talk about what would be an instance that maybe that would not, even if you're 10, that baby still might not be going to come through there. And then it's got to pass through the vagina and come through that perineal area. Sometimes when we come through the stretchiness of that isn't enough, and sometimes the perineum will actually tear. Sometimes the doctors will do an episiotomy to make sure the baby comes through. So here is how we do. Now we're going to change gears a little bit, and we're still on the passageway. We're going to look at here, what is the difference in dilation and effacement. Effacement just means sometimes your cervix is kind of thick. Effacement means that it's going to get really, really thin. This is measured in percentages. So you will be like 10%, 20%, 50%, 60% effaced, thin. Dilation is measured in centimeters. So it'll be 1 centimeter, 4 centimeters, 9 centimeters, 10 centimeters. So your centimeters is going to be here, kind of telling you what centimeters it is for that head to come through. Okay, we're going to switch gears and we're going to start talking about that passenger. The passenger is actually the baby. And this is the most important in relationship to that labor and the birth because it is the largest part and the baby may not be able to get through. It's, you can't compress what isn't going to compress anymore. So we have something that happens and it's called molding. So if you look here, when a baby's born, they have an anterior fontanelle and they have a posterior fontanelle. Then they have these sutures here, frontal and these side sutures. Those sutures will actually overlap on top of each other and they will mold to allow that baby to come through that passageway. Some babies will have more molding than others, but it depends on the size of the baby, the size of the head. So if this baby would have like a hydrocephalus where the head is very large, or you have a very large infant, you got a 10-pound baby that's trying to come through, that head may not be able to come through there. Now, in reality, the head is the largest portion that's going to have to come through. However, we do see, which we'll talk about that later, sometimes they say if the head can come through, the shoulders will become pliable. However, we have seen sometimes babies will get what they call shoulder dystocia, where the shoulders will get caught inside there. And we'll talk about that further on, but that's just a complication of your passenger. So we're going to talk about a few different ways that the fetus is going to be inside, how it's going to be laying, what position it's going to be in. So when we talk about the fetal lie, that's the position on the long axis of the fetus in relation to the pregnant woman. So this baby is going to be longitudinal. So it's going to be up and down. This baby is going to be transverse. It's going back and forth. Oblique is going to be to the side. So you're going to see, and so it's important for us to know, is that baby longitudinal? Is it transverse? Is it oblique? Is it coming in at an angle? So those are all important things for us to know to be able to successfully deliver that baby. Then we go, so that was the fetal lie. Now we're going to the fetal presentation. What is coming out first? So what is the first part that's going to enter the pelvic inlet, or that very first portion? So there's three main presentations. You got head, feet or buttocks, or shoulder. So those are the three main presentations that you're going to get. This is the majority of what our babies are going to come through. This here is breech. Most of the time, most physicians will do a C-section if the baby is in breech position. Shoulder presentation is not real common. It's when the baby's coming in obliquely with the fetal lie, and the shoulder is going to be the first presentation. Many times this is going to be a C-section also if the doctors are aware that the baby's in that position. Now, sometimes you're thinking, well, why would the doctor not know? Well, if they've never had any, a lot of times physicians are going to know that they're in breech because they've been coming to all their prenatal visits. They've had ultrasounds. We know where the baby's at. Sometimes if a mom just comes in and they haven't had any prenatal care, sometimes we don't always know what position or what fetal lie that baby is going to be in. So looking at this, these are your positions. These are the different types of different types of breech positions that you can get. This will be a footling breech. This would be a frank breech. And so you just got to kind of know, most of these are all going to be a C-section. However, sometimes I have seen them deliver breech babies when the feet have came out first. The only problem when the feet come out first or the buttocks comes out first, that is not always the biggest portion of the baby. The head is the biggest portion. So, that is a problem that we can get into if the mom delivers the body, but we can't get the head out. Then we go into a lot of problems with, hypoxia with the baby, difficulty getting the baby out. So there are some complications that can occur with that. So then we look at the fetal altitude, the fetal attitude, and determine the presenting part. And this is in relationship to the fetal parts to one another. So basically, what relationship is it to the feet, to the chin? How are they coming out? So if you look up here, you can see how the head is going straight up and down, how this head is a little bit different, and this body's curled a little bit more. This head is tucked. This one is not. This one, the brow is coming down first. This one is a face presentation. So we get flexion, this one, military, brow, and we get face presentation. This one is the best. If we can get the flexion, so this baby's chin flexes in and the posterior occipital comes out first. That's the best presentation. These other ones are going to probably create a more difficult and long labor. So we look at that position. As far as the presenting part, if the baby is in vertex, it's usually going to be the occipital, which is the back of the head. This is the best position for the baby to come out. Brow position would be the frontum or brow position. Face would be the mentum or the chin. Breech is sacrum and shoulder is scapula. And that is just basically in relationship to the presenting part and the reference point of what we're looking at. So fetal position, the presenting part and location to the reference point, kind of what we talked about in the last one. So the first letter, I don't want you to really remember a lot of this because this isn't super important. The best thing to know is what position the baby's in. Is it vertex? And how is it coming out? Is it longitudinal? How is it coming out? And what presenting part is coming out? Now, the presenting part can either be right or left. So it's going to be right or left on the baby's head. And the second thing is we're looking at the fetal position. And the fetal position is what we talked about a minute ago. Is it occipital, frontum, mentum, sacral, or scapula? That's the second number. So is it right or left? And what presenting part is the middle part? The last one is going to be your fetal position. The presenting part located to that reference point. That's your third letter. Is it anterior, which means it's the front of the pelvis? Is it posterior, which means it's the back of the pelvis? Or is it transverse, the side of the pelvis? The best position, which we'll talk about that here in just a minute. But so you can kind of see, if you look really closely at these pictures, you can kind of see how they're coming down. Left occipital anterior and right occipital anterior is the most favorable for a vaginal delivery. Any of the other positions are probably going to make labor more long and a little bit more difficult. Now, I do want to mention this is left occipital and these are both anterior. What if our baby was posterior? Posterior just means that the occipital or the back side of their head is up against the posterior of the mom or the buttock side. Anterior means that it's up against the frontal side of mom. So it'd be the front of the pelvis. Posterior is more difficult. That's where they have more difficult labor. It's usually much more difficult to get the baby through. They have severe back labor. The baby has a difficult time coming down and ascending down into that and descending down into that pelvic cavity. So anterior is always the best. Posterior is going to be a little bit more difficult. So now I want to look at as far as fetal station. What is the station? So think about that as being a station. Where am I at in my station? Anything negative is probably not good. Positive is going to be good. We look at zero station as being our ischial spines. So our ischial spines are right here. You can kind of see the ischial spine sticking out there. That's station 0. So that means that this top of this baby's head would be at that ischial spine. That would be a 0. Anything above that is going to be a 1, 2, 3, 4 and going to be a negative. That means baby hasn't really technically engaged into the pelvic cavity. Baby's still kind of hanging out up in here. Positive station means that we're going below the ischial spines. Anything positive is good. So when the doctor checks them and says they're at a +1, that means that the baby has passed the ischial spines and the baby is starting to descend further and further into that birth canal. And that's what we want to see happen. Okay, so now we're going to go to the powers. The powers is basically your uterine contractions. How much are you contracting? So this is going to be really important for you to know. Effacement and dilation. Those contractions in the very beginning of labor are basically just dilating and effacing that cervix. That is the purpose of those contractions during that first part of labor. So stage 1 labor is pretty much all the contractions are doing is trying to efface and trying to dilate that cervix. So remember, effacement is in percentages, dilation is in centimeters. Then we're going to look at 3 other things. We're going to look at frequency of contractions, we're going to look at duration of contractions, and we're going to look at intensity. You will need to know these 3 things. Frequency, how frequent are the contractions coming? So that means we're going to start at the beginning of one contraction to the beginning of the next contraction. That's your frequency. That is how often they are coming. So the beginning of one contraction to the beginning of the next contraction. Then we want to know duration. How long are they lasting? How long are they lasting? Are they lasting 20 seconds, 30 seconds, a minute? How long are they lasting? That's the duration. And then intensity. How hard are they? How strong is those contractions? Some moms, will tell you the contractions are super, super strong, but you feel their uterus and you can kind of still push down. A lot of times they tell you to push on the bridge of the nose, and that will give you how hard it should be. The only way to really know how difficult or how intense these contractions are is if we put an internal uterine monitor in. If we put an internal uterine monitor in, it usually will give us how intense those contractions are. So that's kind of how that will help. Now, in stage 2, your contractions are basically helping mom push that baby out. So first stage is to efface and dilate. Second stage is the contractions are going to be to push that baby out and help mom get that baby out. So this slide right here is going to be pretty important to know. So the power still, make sure you know those. There is a resting interval that is between your contractions. We want mom to always have some rest between those, because when mom is actually contracting, baby is not always getting the most. The placenta is kind of being contracted too. When it's contracted, sometimes those placenta vessels that are going to the baby, the umbilical cord, are not, the placenta vessels getting to the placenta are not always getting the adequate oxygenation that they need, maybe the nutrition that they don't need. So we really want mom to have a good relaxation so the baby can get reoxygenated, the baby can get, we'll tell mom to take some really, really good deep breaths. Sometimes if moms aren't breathing real good or they're really having a difficult time, we will go ahead and put some oxygen on them. Most of the time we'll put it on by a face mask just so we can get them increased levels of oxygenation, get into that baby. So let's look at this right here. So here's our contraction. Remember, this is going to be our frequency. So the beginning of one to the beginning of the next one is our frequency. Duration is from the start of one to the end of one. The peak or the acme is at the very top when the peak of that contraction is happening, and then we get the decrement going down. So just make sure you understand the frequency is from the beginning of one to the beginning of next one. Duration is the beginning to the end of that contraction. Now, the last thing we're going to talk about is the psyche. This is basically mom's thought process and how is mom doing. It's very, very important, and it can influence that labor process. If you get a mom that comes in and she's extremely anxious, she's extremely scared, she's never had a baby before, she has no support system, she's not done any classes to help her doing this at all, she's never seen a baby born, this is going to be very difficult for her because she doesn't have that that picture or that image, or she hasn't been in that experience. She hasn't experienced that. So it is going to be difficult. And sometimes that can play a major role on how well labor is going to go, because they can actually, keep themselves from contracting and dilating and getting things to happen like they should. So we want to make sure as the nurse, you've got to really support that mom. Make sure you support that mom. Let her know that what she's doing is great. Try to relax between your contractions. Try to, breathe. Make sure that you're getting plenty of oxygenation. So it's important that we get those moms as comfortable as we possibly can. So the process of labor, remember when we talked at the very beginning of the chapter, all 4 of these P's have to work together. If the P's don't work together, then a lot of times we may not have a successful vaginal delivery, and we may end up with a different type of delivery. We don't really know what causes the onset of labor. We think that there's several different kinds of things that work together to cause labor to happen, but we think it's more a combination of a lot of maternal and fetal hormones that are coming together that are making labor happen. So we know that progesterone is going to be increased, oxytocin from the brain has to be stimulated, and so that pituitary gland has to produce that oxytocin to send it on down to make sure that uterus is going to begin to contract. We got to have prostaglandins. The prostaglandins are going to start being produced to help contract that uterus. And we got fetal cortisol levels that are going to go up, letting the baby know, okay, things are getting ready to happen. So we think about those types of things. So when you think about anticipatory signs of labor, there's several anticipatory signs. Sometimes they may be 48 hours, 72 hours, 8 hours before labor is going to start. But a lot of times the moms will get kind of nauseous. Excuse me. Many times they will have diarrhea. It's just the body's response to all the prostaglandins and all the hormones to relax that gastrointestinal system, and they will start with diarrhea, and it's kind of like nature's way of clearing out that GI tract. Years ago we used to give enemas. We don't really do that anymore. It's not considered to be a problematic thing because we keep them clean throughout the process of labor. Sometimes they will expel their mucus plug, and sometimes that's just from fetal pressure down there. Lightning, when the baby actually drops down into the pelvic cavity. Braxton Hicks contractions. Sometimes Braxton Hicks contractions can start as early as like 16, 18 weeks. And it's just a tightening and release, But it's not doing anything. It's not dilating and it's not effacing the cervix. We just call those practice contractions. Rupture of membranes. If the membrane's ruptured, the mom has to go to the hospital. So that would be one indication. If you got a mom that says, I don't really know when to go to the hospital. If their membranes have ruptured, they have to go to the hospital. If they get a burst of energy, a lot of times they call that nesting, and they will get this burst of energy, and they're like, oh, I'm going to get all the laundry done. I'm going to sweep the floors. I'm going to get on my hands and knees and make sure everything is ready for this baby to have it all cleaned. So we'll see that in these moms, and we just call that nesting, where they're getting ready for things to happen. Sometimes we will see weight loss in that last 2 weeks, just because sometimes they're not able to eat real good because all the pressure and indigestion, all the things like that. Cervical ripening, effacement, and dilation. So when we have those Braxton Hicks contractions, how do we know they're not doing anything? If the Braxton Hicks contractions are coming, or those contractions are coming, and you're seeing bloody discharge, that usually means that is active contractions, and the cervix is starting to show signs of opening up. If the contractions have no bloody show, that's what we call it, bloody show, then we're not probably thinking that it is active labor. Because when the cervix starts to dilate, there's little tiny capillaries in there, and it has a very large blood supply in there at this time, especially with the baby being there. So when that blood supply starts to happen, any little dilation, any little thing is going to cause breaking of little capillaries, and we will get that bloody show. So you will see that. So a lot of moms don't really know what is the difference between true labor and false labor. So, as far as true labor, you're going to see those cervical changes. You're going to see that cervix start to open up and change. Membranes, False labor, membranes are going to be intact. Now, true labor, the membranes might be bulging. They might not be broken, but they're bulging, or they might be ruptured. Just depends. Bloody show, there will not be any bloody show with false labor, but there will be with true labor. Contraction patterns are going to be very regular with true labor. They're going to be coming every 2 to 3 minutes, every 4 to 5 minutes. You can actually time those. With false labor, a lot of times moms are very irregular. They might be having a regular pattern, but they get up and walk or they go do something and it quits. So that's false labor. As far as pain characteristics, some of the false labor might be described as like tightening, but it's not typically that discomfort that you're going to get when true labor starts to happen. And they start getting that cramping sensation and that true radiation from the sides of their abdomen all the way around to the top. Effects of walking. Again, that's the one on false labor. A lot of times if they walk, their labor kind of quits and kind of stalls. Where if it's true labor, it does not. The contractions continue and sometimes they will even become stronger throughout that walking process. So, mechanisms of a spontaneous delivery. There's a lot of different things that have to happen. We call these the 5 cardinal movements that the baby has to go through to get out. So the 5 cardinal movements, the baby has to engage and descend. That's when the head looks like this. Then the baby has to internally rotate to get through that pelvis. And then it has to rotation. They have to externally start to rotate. See how that head is here and it rotates fully here? Then the baby has to start to get complete and come through that true pelvis at the bottom. The baby's head actually has to get over that pelvic bone. So it externally rotates to do that. And then once the head's out, the body kind of turns and twists to come on out. All of these 5 cardinal movements have to happen. If they don't, sometimes the baby just does not descend and come out like it needs to. And the doctor may have to go in and help do some type of maneuver to help that baby come through. Okay, stages of labor and the duration of labor is going to be kind of important to know. So the first stage of labor, again, we've talked about what the purpose of the contractions are. It's just effacement and dilation. Usually your latent phase is kind of that phase where mom's feeling good, mom's happy, mom might be filling out the baby book, she's watching TV, she feels pretty good. Then and that can last a long time. I've seen it last more, the average is 8 to 9 hours, but I've seen that up to 18 hours. Active phase is when mom is 4 centimeters to 8 centimeters. Mom is not quite so happy right now. She feels every contraction. This is when she's probably going to be getting her epidural. She wants the epidural. Her mind is going to be focused on those contractions. It's going to be focused on that pain. I've got to get this under control. And then she's going to go into transition. Transition is the last stage of that first stage. This is when mom is 8 to 10 centimeters. This is the most difficult time during labor. A lot of times moms will get nauseated, they will throw up. This is the time when they say, I can't do it. I can't do it anymore. I can't push. I can't do it. I'm exhausted. This is not going to happen. I've got to do something. You got to get this baby out. You just take it by C-section, whatever you got to do. So this is the most difficult time for moms. And this is when a lot of times if mom was going to get pain medication, we are not going to give it during the transition phase. Because when we give that pain medication through the transition phase, those pain medications, cause mom to kind of be loopy and decrease respiratory rate and all of that. Same thing's going to happen with baby if we give any type of analgesic at this point. So during transition, moms aren't going to really be able to get any pain medication. But if they have an epidural, that should last throughout this stage and help with getting them through. Second stage is when baby's complete. When mom is complete 10 centimeters to birth. That's your second stage. So first stage is all the dilation and effacement. Once you get to 10, it's called second stage now until the baby is born. Third stage is the delivery of the placenta. You have a Schultz side and a Duncan side. The Schultz side is the shiny side, because I always think SS, shiny side. That's the side that was up against the baby. The Duncan side looks more like kind of ground beef, and that was the side that was up against that was the side that was up against the uterus when baby was inside mom. Fourth stage is just the recovery. So what kind of physiological adaptation is happening inside mom? So if you think about how difficult labor is, if mom was to go try to do vigorous exercise, labor is typically kind of like that. It is extremely difficult. It's very, very hard for her body to go through this. She's going to be using lots of her internal reserves as far as like her sugars and all of that kind of stuff. It's increased her oxygen demands. It's increased her cardiac output. Her heart is having to work harder. Her respiratory system's having to work harder. So at this point during those last bits, it might not be, we might want to go ahead and put oxygen on mom by a face mask. Make sure you turn those liters up high so mom doesn't breathe in her own carbon dioxide. So the liters have to be up to 10 to 14 liters of oxygen going through there. That the gastrointestinal system and that urinary system is going to be affected. Sometimes moms will have, if they have an epidural, they'll have a catheter, but sometimes the pressure, moms can't pee. So they get, the urine stays in, and sometimes if the bladder's full, the baby can't come through. So we have to make sure that bladder is empty. So if they don't have a catheter, you might have to, every now and then, intermittent cath to get that bladder empty so the baby can actually descend down and get underneath that the pubic bone to get out. The GI system, like I said, sometimes we'll get that diarrhea. It's not uncommon for moms to have stool during delivery. That is totally common because when that baby comes through, it's pushing those intestines and things are just moving through. And there's so much pressure down there. You don't know if it's, GI pressure or rectal pressure or baby pressure. Sometimes there's so much pressure, it's hard to know what is causing that pressure. But many times during that laboring process, we'll really only allow mom to have clear liquids because we don't always know if there's going to be a C-section. So it's better to keep mom on clear liquids, keep her hydrated. We are giving, most of the time moms are going to have an IV and they're going to be giving isotonic fluids, lactated ringers to make sure moms are hydrated. So white blood cell count, just remember white blood cell count always goes up in your moms. Anytime there's inflammation in the body, which delivering a baby is going to be lots of inflammation, it's the body's response to build up those white blood cells. Because if you got inflammation, you're going to have lots of white blood cells to fight off any type of infection that might happen. So we're going to be looking at that. Now, if you get a mom that her white blood cell count is very elevated and we're looking at her bands, bands are types of white blood cells, and we see any bands, that is more indicative of a septic kind of thing or an infection kind of thing. So if you get a mom that has an elevated white blood cell count, she has fever and she's got chills, now I would be thinking more infection. But if mom is feeling fine, all of her lab work looks good, then the white blood cells are probably just a physiological adaptation of just being pregnant. It is not uncommon for our clotting factors to also go up during this time because your body is like, okay, I know there's something happening in my body. I want to protect my body from hemorrhage, so I'm going to build up extra clotting factors. So during that second and third trimester, they will build up those extra clotting factors to prevent any bleeding during that labor process. Okay, so, I think we might have talked about these already. Now, that was mom's adaptation. Now we're going to look at baby's adaptation to labor. So what happens to baby during labor? A lot of times these babies will have increased intracranial pressure on their head as they get through that birth canal trying to come through. Again, we have a lot of interruptions in oxygenation to the baby. So giving mom oxygen is going to also give baby that extra oxygen that they need. The baby's pH is going to slowly start to decrease as they're coming through that birth canal. We always do a pH level, a cord pH on our babies when they're being born, because if the pH is too low, that can indicate that the babies can have some difficulties. And sometimes if it's very low, sometimes that would be an automatic admission to special care nursery. And now we're even looking, if it's low, sometimes we will put them into a hypothermic state. And sometimes we're sending those babies to St. Louis to do that. As that baby comes through the birth canal, it squeezes that baby and squeezes the lungs and pushes through pressure, pushes all of that fluid out of the lungs and increases that surfactant secretion into those lungs through that passageway. And that is a great thing that can happen to our babies. They don't get that when they have a C-section, so sometimes those babies have a little bit more respiratory problems after birth. It's not uncommon for a baby to get this thing called caput succedaneum. This is just where on the top of their head or wherever the presenting part was, usually the occipital, it will be very swollen, and you can kind of push on it, you can feel kind of fluid in there. It's external underneath like the scalp membrane. Now, a cephalohematoma is a little bit different. We'll talk about that later on, but that is where it's actually down under, and it's actually on one side or the other, and it does not cross the suture line, and they get like a pooling of blood in there. And there is a difference between the two, but we'll talk about those more later on. Ecchymosis might be present on their buttocks, or it might be present on their face if they have a facial presentation. Sometimes you'll see what looks like almost like petechiae all over their face, and that's just because they came and all that pressure was on their face coming down that birth canal. And that is it. That is our labor process, and we will move on to some other parts of labor.